So, Ali, tell me a little bit about the issue of what treatment, dental treatment specifically, a patient may have had in the last month, how that may influence your thinking in terms of making a diagnosis of a pulpal problem.
Well, that kind of brings us to the whole third step of our patient interview, which is the dental history.
Okay.
The dental history is what we're doing during the dental history interview portion of the patient is capture basically two pieces of information. As you said yourself, we're trying to see what is it about the history of the treatment that the patient has had that would relate to the chief complaint that they're presenting with. But also at the same time, we're trying to do something more important, which is to take the patient's chief complaint and try to make sense out of it by kind of, getting deeper into the meaning of the chief complaint, right? So what is the chief complaint consists of? The chief complaint is basically the main symptom that the patient's coming to see us for. But as I mentioned earlier, we don't have access to the patient's brain or their feelings or how much pain they're feeling. What is the quality of the pain? What is the quantity of the pain? Is this pain, how long ago did it start? And these are the things that we need to investigate in detail. And the information we get from the patient helps us make more sense out of the chief complaint and build a picture that, with the understanding of the pulpophysiology that we spoke about, we can try to make more sense out of in terms of contextualizing the patient's chief complaint and the history of their present illness, basically.
So if we were to start to look at the patient's chief complaint in the context of that which we're looking at in terms of past treatment, and then bringing it to the current, you're with the patient, you're now starting to look at this patient's chief complaint in their, quote, own words, and they start to talk to you about onset, as an example.
Yeah.
And talk to me about the kinds of things that you would be trying to categorize as qualifying the chief complaint.
So during the dental history portion of the interview, what we're trying to do is to kind of find out what was the onset, duration of the pain, whether there is a localization of this discomfort, what is its intensity, what is the quality of this of the pain that they're having, and the duration, or any factors that could provocate or bring on the chief complaint. Again, it goes back to what we discussed, and that is that the whole goal of diagnostic process is to duplicate the chief complaint. So we're trying to understand it by asking specific and kind of surgical questions that are very precise in terms of the answer that we can get, which are meaningful in the context of the pulpophysiology that we're aware of.
Okay.
So, for example, let's talk about the onset. In terms of the onset, what we want to know is what was the origin of the pain? How long ago did it start? Because, if a patient tells us, well, I've had pain on this tooth for the past 6 months, and then it tells you something else than when they tell you the pain started 2 days ago, So onset is important because a lot of the information that we're trying to capture has partially to do with making a diagnosis and partially has to do with triaging the patient for the treatment, right? I mean, a patient that is having acute pain, once we find out that the level of intensity of the pain is so high, is going to need treatment that's a little bit more urgent than somebody who's just had a pain, and I've been having a little bit of sensitivity to cold for the past 6 months. So the origin and then the stimulation factors that make the pain worse are very important in terms of knowing that, because then, for example, if you know it's cold versus hot, then it gives you an information about whether you have your A delta fibers involved, whether your C fibers are involved, how much it's progressed, because as we know, it starts from cold sensitivity and it gets to the hot sensitivity. So when a patient's stimulating factor is cold, then it's a little bit earlier than somebody who's hot, sensitive to hot or to heat, if you will. So also whether the pain requires stimulation is another important thing. Something that requires stimulation is basically not a spontaneous kind of pain. And we mentioned that spontaneous pain is more associated with irreversible pulpitis than pain that is triggered by some kind of a stimulus. Mm-hmm. So it's important to know. The other thing about onset of pain is, for example, whether the pain is intermittent or not. Most pulpal pain is intermittent. It's not relentless over long spans of time. It usually, the duration of it is somewhere in the order of it gets triggered, it's a few minutes to hours. You can't have pain that's constant for like 3-4 days in a row. There are points of, that are relents and it kind of subsides. And you certainly can't have pain where the patient coming in and say, I've been in constant pain for the past 2 weeks. That just does not happen with pulpal disease. It progresses down to a point of doubt. So that is a point where you have to actually interview the patient a little bit better, because some people could be a little bit more hyperbolic and say constant pain to them is the fact that they've had pain several times. So you need to be more precise in the way you ask the questions. The patient interview, as we said earlier, is about communication. It's about understanding what they're feeling, where you don't have access to basically tapping into their brain and to their body to see what's going on. And that's where asking precise questions really matters. So the duration, for example, is important to know how long does it, when the pain comes, how long does it last? If it's just seconds, then you know that you might be dealing with either dental sensitivity or reversible pulpitis. So in those cases, that it just orients you towards thinking one way or another compared to, about your pulp and apical diagnoses. And pain that is constant, Dennis, I have found over my practice time, that lasts for a long time, tends to be a little bit more of a myofascial origin. So somebody might be having a problem with their one of the muscles is having a trigger point, has gone into status of basically into a spasm, and then they're having just constant pain that's coming from that
Sometimes
area.
you see that after someone has had even 2 weeks earlier dental treatment.
Yes.
And kept their mouth open for an extended period of time, and then walks into you, or the dentist says, well, listen, they've returned to their dentist saying, I have pain. He can't really figure out a specific tooth that's a problem, but the patient really can be having some serious discomfort.
Absolutely.
Pain.
Absolutely. I mean, to the patient, that is pain. They don't care what the source or the cause, what is the histopathology,
Right.
the keys to relieve it. And in people that are prone to a little bit of temporomandibular disorder and have problems with their joints, opening up for long extended periods of time has been shown to trigger a little bit of a myofascial problems postoperatively that could last for quite a while if it's not treated. And the treatment for that oftentimes is creating a device so that you can deprogram the muscle and get a little bit of relief on that front. Another factor that I think is important we need to talk about during the dental history is the localization of pain. Is it localized to an area, or is it diffuse, referred, or is it radiating all over the place? We're lucky when you have a patient where the pain is localized and they know exactly, this is the tooth that's hurting, this is when it's hurting when I'm tapping on it. Again, that in itself is not diagnostic, because don't forget there could be a number of different things that could be causing that. But it helps at least focus the problem to an area. Many times you may have problems that are diffuse, and as we mentioned earlier on, because of the lack of proprioceptive nerve fibers in the pulp, when you have early stage pulpitis, the pain just cannot be localized. The patient does not know where it's coming from. So that kind of tells us that you're having a little bit of pulpitis when you have diffuse pain, or you could be having a non-odontogenic pain. So these questions all just trigger different possible paths. It's all about narrowing down possibilities as you move forward in questioning and interviewing the patient. And hopefully by the end of the whole thing, you have some kind of a pattern that you've developed that makes sense to you, and you can tap into your knowledge base and come up with a diagnosis.
So let me ask you this, Ali. In terms of the intensity of pain, one has to really recognize that every patient kind of brings this sense of intensity a little bit different.
Yeah.
And obviously, there's some of us deal with pain differently than others. So how do you bring in this issue of intensity? How do you try to draw a perspective on that issue?
It's an excellent question, because pain, Dennis, is a very subjective experience, and what is severe to you might be more or less severe to me. So because of the
I can assure you it is.
I'm sure that's the case. I'm not as tough as you. But what is going on is that the best way to create a systematic approach to evaluating pain, historically it's been about talking about mild, moderate, or severe pain, but in newer ways to use actually a scale of a 0 to 10 and tell the patients that 10 is basically the most unfathomable pain you can imagine, and worse than childbirth, whatever,
Okay,
right?
all right.
And I tell you, pulpal disease can be painful. I've had a lot of patients tell me that it's at 11 on that scale when they're coming from a situation in which they're having acute irritable pulpitis or symptomatic irritable pulpitis and apical periodontitis
So,
at the
so when
same
my
stage.
wife says to me, "Listen, you don't know what pain is. You didn't have a baby. I've had a couple root canals.
I can say I've had a pulpitis, actually. I've had one of those pains that
oh,
wakes.
yeah.
Oh, God, it is pretty bad.
Yeah.
It is actually, it has been the worst pain that I've ever experienced. So
Let's
it's a little
hope
more personal
let's hope-
experience
let's
to
hope that
share
it
with the
continues
audience
to
here.
be, right?
That's right, exactly. I mean, to be honest, it does wake you up in the middle of the night, and that is actually another big tell on it, because the intensity that you first get out of the patient should be put in context about, also at temporal fashion. Is it happening more in the morning, more at night? Pulpal pain tends to get worse at night when the natural corticosteroid level in the body is lower. So the natural, opiates as well as your own personal and physiological compensatory mechanisms go down for relieving pain naturally. So then these inflammatory things get worse. Yeah. And so you have more pain. For me, my personal experience, I woke up in pain. In fact, my dream was that my head was melting. And I thought, I'm dying. That's it. I'm dead, Dennis. So I basically, what ended up happening, I woke up and it was a toothache.
I actually remember that. I do,
Yeah.
because you called, and I remember that next day.
Exactly.
You describing it.
Exactly.
And you were like so totally nuts over the whole thing. So
Yes. I mean, how often can you be talking about this stuff and experiencing it at the same time? It's, it's one of those unfortunate occasions where I can say I've been there to my patients.
Right.
But it is really intense, and that's really the important thing to realize. So, it should never be taken lightly, and we should really respect patient's own personal view of how bad the pain is. The quality of the pain in terms of being dull, sharp, or throbbing is important to know, because it goes back to the pulp biology portion of what we talked about. Dull pain is normally associated with a little bit deeper kind of pain coming from the C fibers, the unmyelinated C fibers, whereas the sharp shooting pain is usually a function of the faster traveling A delta fibers, and that is, just kind of deciphers the level of the inflammation.
Mm-hmm.
Of course, sharp, sometimes people talk about electrical kind of pain. Then it's important information to know, because it may tell us that, we're talking about a form of neuralgia possibly, a neuropathic kind of pain. Also, burning sensation for some people has been associated also with these types of autonomic-based neuralgia situations where it's nerve-related, not necessarily pulp-related. So a throbbing pain is a function of the intrapulpal pressure kind of going high, and then the C fibers oftentimes get that sensation of the heartbeat in the pulp, so that you end up having a throbbing pain. And the duration is also important to know, because whether the pain that you're having is short and just brief versus long and lingering is another demarcating factor to know whether you're having reversible versus irreversible pulpitis. If you just have cold, it zaps you a little bit, it goes away. If you find a source and can address it, you might be able to revert the pulp and have the pulp heal and not need a root canal. But if it lingers for a long period of time, then you might be dealing with an irreversible pulp situation, in which case you should be doing a root canal. So this is another important factor to know. And also knowing what factors make the pain worse, such as biting pain, hot, cold, and chewing, are also very important when you ask the patient without actually doing the testing yet, because their testing is done at home. And it is more important, because you would be able to get more information about what the chief complaint is. Biting and chewing pain could be due to apical periodontitis. Biting pain that is released, when I bite down and I release, it kind of gives me a zing. Or every time when I'm chewing on this tooth, sometimes it suddenly gives me a zing. Some of those could be related to two possible, because that is dental sensitivity, the dental hypersensitivity. It comes from dental tubules. It's not an infection. That could be related to either a debonded restoration, where you have cuspal deflection, as we talked about during the pulp biology portion, or a crack, as in the old term crack tooth syndrome, which actually no longer is really used that often. It's just not clinically a diagnosis anymore. But it describes a series of symptoms associated with a tooth that has a crack and deflection of the cusps.
let's look at this from this perspective. You've given us some sense of duration and all these various different things the patient might be telling you. But some of us tend to, kind of get into the process of diagnosis without really getting a lot of information about recent dental treatment.
Yeah.
I have to, I'm myself, every once in a while, I'm thinking back on it, and I've kind of just gone right after, making the diagnosis and kind of not even asked them, what's going on in terms of the last.
Yeah. I think that's a really critical part of the thing, and that's what you were alluding to at the beginning part of the lesson when we were talking about the dental history. The dental history is about the patient interview portion, that is just about the quality of the chief complaint and so on, but also about capturing information about what recent restorations and treatment was done. Because oftentimes, what is pulpal disease? It's a reaction to an injury, and treatment can be causing the injury, right? So oftentimes, if I see a patient that has had a crown and is complaining of pain in the area, my first question would be, how long ago were the crowns done? If the crowns haven't been endodontically treated and a patient has had a crown, not very often, but actually about 10 to 20% of crown restorations that haven't had root canal therapy end up needing root canal therapy. So, and that happens most of the time fairly, within a year or so after the crown, sometimes within 2 years of the crown, where the patient's had a history of thermal sensitivity and so on after the crown was placed, slowly it deteriorates. Most of the acute ones are within 6 months, but then, within 2 years, it can happen as well. Then usually there is a kind of a lag period where everything is good from 2 years to like about 8 to 10 years. And then after that, depending on how well the crown was made, you could have leakage from the crown or the restoration, and then you end up having pulpitis as a result of that. So understanding when the restoration was placed or done, it could tell you whether you've had chronic injury from a leaking restoration that is old, or acute injury from the treatment that was rendered. So these two pieces of information are very important to know because it helps you, focus your attention to some different areas. If I take an X-ray from a tooth and there's multiple crowns without root canals, and the patient's complaining of signs and symptoms that appear to me to be pulpitis, I'm very quickly trying to make sure that those teeth are the cause or not, and then I try to ask the questions regarding those specific things. Patients that have had root canal therapy, if the root canal is old, if it's fallen apart, that information is important to know. How long ago was the root canal done? Because a root canal that gets infected, again, it could be, if it's not the same thing as a crown, it may be done very quickly thereafter, and it may not have fully cleaned or removed the source of bacteria, or it's very old and the coronal restoration has failed. It's created leakage, coronal leakage, and it's recontaminated the root canal. So that's why you could be having pain. So it seems that with all dental restorations and treatment, you have a grace period. Most of the problems are early or late. Is it kind of like, flying a plane? Most of the accidents happen during the takeoff and the landing. The time in the air, everything is good.
Right,
so,
right.
All right. So I think we've kind of talked about the patient interview portion of the of this course so far.
Could I ask you one question?
Sure.
How do you physically? Let's say that you're not the first person to see the patient. You have an assistant who talks to the patient.
Yes.
The assistant does a little interview, kind of takes the chief complaint down in the patient's own words, and you say, "Look, whomever your assistant is, please try to the best of your ability to put this in the words of the patient." On the sheet, the worksheet that you're working with from that point, do you have a list of each of these things that we just talked about with classifications of, for instance, intensity, immediate, sharp, dull, etc., duration, do you have, where is this recorded? In what form is this recorded?
It should be recorded in a systematic fashion in the patient's chart.
Okay.
So, and that should be included in there. So a form has to be developed that includes all of these steps on it.
All right. So it's important that all this is in writing.
Yes.
It's important that you take the information, get it into the patient's chart, and it's documented as such.
Absolutely. All of this information is a part of the patient document that will be legally required to be a part of the diagnosis. Otherwise, later on, if you have to defend your diagnostic position, you have to have a basis for saying that your pulpal and your apical diagnoses were what they were. You can't just come up with it. So you have to have the documentation for arriving at the diagnosis as well. So I think this wraps up the patient interview portion of the diagnostic process. And now we're going to talk about the clinical evaluation. And it's important to realize that up until now, we've only been communicating with the patient. All of the time we've spent right now has been about oral interview. Now we're going to do an oral exam, an extraoral exam.
Okay.
And let's come back and do that.
Okay, sounds great.